His knee and arthritis. I didn't quite get through all the arthritis for the last group, so probably end up in the same place just to be consistent. And things that are, and this is where we're working, starting with the knee particularly. Come on in. Didn't miss anything important yet. We're trying. Okay, couple of things. The major part of this announcement is this is the end of the 8th week. We're past the halfway point, or just technically 7.5 weeks would have been the halfway point. It gets hard now. Trust me. We're doing muscle physiology and nerve physiology for our last 2 units, and also the autonomic nervous system. Those are a lot of stuff going on. There's a lot of stuff. I dedicate almost the whole 3rd exam to muscle physiology. That is how complex it is. So, I mean, it's almost like a 1-unit study. To that end, because I had a number of students inquire with me, and I'll send the link to everybody, or I'll forward the email to everybody about tutoring that's available, and whatever the lady got back to me, whatever the student success area is, whatever the acronym that they're using. The lady just got back to me today because I had a number of inquiries. I wanted to get all the information. So please, we're halfway through this. Things are going to get busy and complicated in a hurry. Just want to let everybody to know like that. So with lab over, I'd like your, not complete attention, but at least most of your attention going forward. Nevertheless, we're going to start here with the knee and go from there. And yes, I will start to put out those review videos. I haven't finished the exam, but the part I've finished, at least, that I will be able to work on. So, I mean, I can't give it to you all until I finish, but I'll try to get at least one out over the week. It's not like I'm seeing. Moving on. Leaves. I have 2 giant oak trees. Terrible. Nevertheless, the knee. Complicated joint for a number of factors. Perhaps most importantly, the complication vis-a-vis the knee has to do with the fact that it's not so much the femoral patellar joint. It has a lot to do with what's going on and the patella is just sort of a complicating factor. That's probably the easiest one. It's a sliding or gliding joint. It basically helps to stabilize the knee. It generates extra power, if you can think of it that way. Sesamoid bones, like the patella, act as a fulcrum. And so that generates power from a leverage perspective, I say, without going into mechanics, which is not my suit. It slides or glides. What it does when you flex your knee, your patella slides down. Basically, it goes along the femur. It doesn't have anything to do with the tibia, even though the patellar tendon attaches there. The patellar ligament rather attaches there to the tibial tuberosity. So as you flex it, it slides down deeply into that articular surface between the condyles. And as you extend your knee, it moves up along that surface. That's really all it does. It's more of a pain. Okay, we could do without it. You don't have to have a patella to function. You and I don't. For an athlete functioning at a high level, whether it's interscholastically, professionally, or a serious amateur athlete, just somebody who likes recreational, that becomes more of an issue. That's there. But if somebody would be in an accident and they had to remove the patella, you get along. It's not like you have to. It's not something that's going to be a life changer per se with regard to that stuff. And that's all it does. It plays a significant role to assist with flexing the knee and extending knee and generating power. The big players are the lateral and medial joints, and those are tibial femoral joints. Okay, and so they are called, in this case, what makes them very unique is all of the stuff going on. You have 2 cartilaginous gaskets that effectively make it a functional joint. You know what the top of the tibia looks like. You know what the femoral condyle is. It's flat against round. I don't know how that works. But you have these 2 gaskets that are wide on the outside, narrow on the inside, beveled, and they create effectively a cup kind of an apparatus that allows the knee to flex and extend very efficiently, and at the same time provide a certain aspect, like with the joints we looked at. Well, it really is classified as a condyloid joint because you have the convexity of the femoral condyles and effectively the concavity of this apparatus from the menisci, the fibrocartilaginous pads, that allows a certain amount of rotation internally when the knee flexes so you can walk, and externally when you straighten out your leg for power. That's how they work. So all of that, and so meniscus is the singular, menisci is the plural. They're not identical. You're going to see, and it's a pretty accurate representation. The artist or the graphic that they demonstrate, which you will see there with regard to what the complexity is. On top of that, now we have ligaments, collateral ligaments for side-to-side stability. One is really part of the capsule on medially. The lateral one is not. Okay, it's extracapsular, and that really plays into injuries per se. Why the medial side injuries are much more common and much more problematic. And we're not done yet. The biggest bad guys in there are the cruciate ligaments, which are anterior to posterior stability. So those cruciate ligaments are within the joint. They're surrounded by additional synovial tissue. Okay, so they're almost separate structures. They have a blood supply of their own. When they're damaged, they bleed profusely in that particular area. That's one of the tells when you would siphon off fluid and you see frankly bloody looking synovial fluid. Oh boy. I can remember my middle son having that when he ruptured his ACL from the activities he was doing when he was doing stunt biking. So all of that plays a role, and you're going to see the degree of complexity as we go through these images that are there. Today, with the MRI and advanced scanning techniques, we're able to assess it very accurately. Years ago, basically, and now everything is in that blue tent that you see in the sidelines where they take the player off the field, whatever sport that they're in, and go back into the locker room or the training room. They would used to be able to test these cruciate ligaments. They'd have somebody brace it, and the team physician or the lead physical therapist would come out, lead trainer, and they'd be pulling the tibia forward and backward. They were doing something called the drawer sign. It's like you have a dresser drawer and all of a sudden you're pulling it out to get something in the back and it comes out at you. If it pulls out farther, it's called an anterior drawer sign. If you push it in and it kind of goes past, and now you're pushing it in past where it should be stopping, that's a posterior drawer sign. And we even said, and the anterior drawer sign means the anterior cruciate is ruptured. Posterior means posterior cruciate is ruptured. And both can be ruptured in severe knee injuries. So, I have a lot of information to share with you about that. Depending on where you're going career-wise, this could be very, very relevant. And if you're not working with a lot of orthopedics and a lot of athletes, maybe not as relevant, but it's important to be familiar with, I think. Here's what it looks like from the side. Very complex. You'll see there are multiple bursal sacs that are always there because there's so much going on. Bursal sacs between here, they call it infrapatellar. This is the patellar ligament. Here you have the quadriceps tendon, the bursal sac here above it. You'll see bursal sacs down here. You have additional fat pads. A bursal sac exterior. Think of how many, when you're down on your hands and knees doing something, how much friction and pressure is there. So again, Mother Nature puts a lot of these things, and some come because of different factors. If there's injuries or, from devices that you may have on, even from tight pair of shoes. You get other joints can be impacted like this. And here you can see the cruciate ligaments. And this gives you kind of from what I was trying to describe as well. And even though you're looking at a sideways view, you can see thicker on the outside, narrow as they go toward the middle. Not as narrow as this. So it's not a bad illustration. This is very good. You see this all the time in textbooks, this typical artist rendition of it. And so you can see they're not exactly the same. The lateral one is more of a C shape, and this one maybe not quite as much. But the big distinction here, the cutaway, here's the anterior cruciate, here's the posterior. The anterior, and you can see, just to complete the thought, you can see the thickness here pretty well illustrated on the exterior, and as it goes, you can see it begins thinning out and then becoming relatively thin. but covering the cartilage. So effectively, you're creating that nice sort of a concave surface for the convexity of the femoral condyle. Hence the idea of a condyloid joint. So, but on this, the anterior cruciate is adherent to the medial meniscus. On top of that, although it's not pictured here, the medial collateral ligament is adherent to the capsule, and the capsule is adherent to the meniscus. So the anterior cruciate attaches to the meniscus. The meniscus is attached to the capsule, and because it's a capsular ligament, so is the medial collateral ligament. The lateral is not. Posterior cruciate ligament is not attached to either. The lateral collateral ligament is not attached to the capsule, and the capsule is not necessarily attached to this lateral rim that's there. So medial injuries, if one goes, you're creating a force that's probably going to impact the others. Not always, but sometimes. That's why you're going to see something down the road that was described. It's not something new on the horizon we just heard about in sport. People have been injuring knees as long as they've been doing activities. Back in the 50s, they had a doctor out in Oklahoma where they had a very, very successful football program in the NCAAs. He described what they call the triad of injuries, which you will see. So that was one of the early books 70 years ago on sports medicine. Sports medicine has come a long way over time. We dealt with it in its infancy. And as time went on, it's remarkable. Can't say it enough. If you saw the athletes, go back and look at, the football games that they'll have, the famous Giants Baltimore game. They have the sneakers game. They have Johnny Unitas. They have an overtime game. But before, football was not king. Football wasn't even queen. Okay? Football was not the number one sport. Baseball. And you see the players. I mean, a big guy was 6'1", 6'2", 225. Linebackers were, 5'11", 6 feet tall, maybe weigh 200 pounds. And these were all pros. So what we see today is totally different. It doesn't mean they weren't great players, but the whole size, training, and everything else. You see the evolution of sport in all sports. The athlete has changed. So as we see, what's interesting, the capsule is strong posteriorly, but anteriorly it relies on a lot of soft tissue structures. And so running from all the tendons that come across that joint and the ligaments is a fancy name called retinacula that you'll hear again. The retinacula is it's not as big and strong as a ligament or thick, but it's stronger than just a piece of fatty tissue that's there. We talked about a ruptured biceps tendon. What holds that tendon in the tendon sheath and in that groove in the humerus is retinacula. So when it ruptures through that retinacula, you push it back in and you sew it back together or over sew it. The way you would do with a garment, let's say you just want to put a temporary fix in. And you know about the knee jerk, and you can see there's a lot of bursal sacs. You don't have to know all these things. In our orthopedics classes, our anatomy classes, you won't get all those things. Here you can see, this is a pretty good illustration. I heard you learned about this. It's called the quadriceps. The quadriceps has 4 muscles, one you don't see here, and that's the one, interestingly, that has the biggest impact on the knee joint itself. You have rectus femoris, vastus, this would be medialis, this would be lateralis. They're massive. That's where the name comes from, vastus. And underneath them is a guy or a gal, if you want to assume gender for it, is called vastus intermedius. That inserts directly into the capsule. And the reason we rehab knees by doing straight leg races with weights and progressively increasing the weights, we talk about that in muscles, is because of the intermedius. That's what by strengthening that muscle, it strengthens the capsule and is able to support the knee. So just a little context where the anatomy plays a role in being able to deal with how that impacts our way of treatment and our way of understanding what goes on. So you got to see the tie-ins rather than, I'm stuck in that. I'm trying to give you the clinical tie-ins that are so important. So here, look at that. Now, look at the fibular or lateral collateral ligament. It's out there. and look at the tibial one, very close to the joint, and indeed it's part of it. So you get a flavor for it here. Okay, so the knee joint, capsular, extracapsular, and those very famous intracapsular cruciate, because they crisscross ligaments. Anterior is larger, thicker. Okay, posterior a little narrower. They don't contact each other. They each can rupture, but the anterior is much more common. When you see non-contact injuries and they talk about an ACL tear or an ACL rupture, it's typically by itself. When you see somebody in a big collision with a knee, then you're going to see this triad of injuries. And that really underscores the amount of time. Non-contact injury, world-class athlete. Rod Woodson, Hall of Famer, played for the Steelers, Oakland, and Baltimore. Consistent All-Pro. He and Deion Sanders were by far and away the two best. He was the best all-around of the cornerbacks. Deion was better in coverage. In the Super Bowl year that the Steelers lost to Dallas, last time Dallas won anything, it's okay. I had to put up with a lot of Cowboys fans over the years. He, in the first game of the season, non-contact, it went down. He played in the Super Bowl. I won't say he was great in the Super Bowl, but he was able to play in the Super Bowl. That's just the quality of his athletes. How good of an athlete was he? He was in the Olympic trials for hurdles, as well as being, a very high draft pick and a consistent All-Pro. Just to give you an idea, athletes are athletes. So all those types of things that are there. So those are really taking a look at these ligaments. The ones in the back you don't have to know about. There's just a lot of them. It's stronger in the back. There's a lot going on behind the knee. So here's what it looks like. It's so busy, I don't even try to describe it for students that are there. So you have the hamstring, tendons of the hamstring reinforcing it, a variety of other ligaments that are there. Busy areas in the body are those natural sort of hollow areas. The axilla, the cubital fossa here, in front of your elbow, the popliteal fossa behind the knee. When you see those areas, a lot of business is being done. So they're very, very interesting areas where there's a lot of anatomy. And for people who go on to graduate levels, those are really complex areas of anatomy that are there. So I'm just trying to acquaint you with the idea of it. So inside the capsule, but outside the synovial cavity, huh? No, they're not. They're in the synovial cavity. They are just really sort of separate and distinct because they have their own synovial lining. Synovial fluid from the knee, per se, is contacting the exterior lining of those cruciates. You don't have to know it. That's just me taking issue. Every time I see something that I haven't noticed before, and I've been doing this for 25 years, it aggravates me. I'm in one of those moods. I know I did not drink last night after the game or during the game. School night. You don't do that stuff. So, anterior tibia prevents sliding and gliding. Posterior attaches to posterior tibia, blah, 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 blah. Nothing major here. Very good illustration. Look at the thickness and then narrowing. So the sort of creating the cup or gasket action. Here you can see the thickness isn't really the area. The anterior is a bit thicker, and they don't really illustrate it as well as I would like it to be, but you can see the level of complexity. We actually saw this view back in the day before, when I first started working with knees as an orthopedic resident. We had a straight arthroscope, not the flexible ones you used to say. We look inside and we see if something was torn, but we didn't have the technology then to go in there and repair it. Now they can do most knee surgeries arthroscopically. So we would then make a cut. You wouldn't cut away the patellar, the quadriceps tendon, which would be here. You just reflect it. You just get it and retract it out of the way, and you actually see what this looked like. And you move the knee, and you see the ligaments, make sure they were intact. You actually see potentially damage in a way the cartilage. Very interesting, because we're doing it under direct visualization. But now nearly everything. So how much it evolved. I had a bucket handle tear and I'm certainly not doing any athletics. I was kneeling a lot to take my kids car seats when they were little, like 2.5 and 1.5, in and out of our Blazer. So it was more like a truck. And then it finally gave way at the local Y when I knelt down. And I heard a rip when I'm trying to pick up toys in the kids' toy room. So I'm fond of saying, no good deed goes unpunished. It's a wonderful expression. I end up with a bucket handle tear that's there. So, I mean, it can happen to anybody with regard to it. I mean, it's relatively uncomplicated surgery to do, and I'll tell you about in a second. So, I mean, there's a lot that can go wrong with these things, whether you're active in sport or athletics or not, that are there. And again, you can see a lot of good views from the illustrations here. This is the idea. It's a great amount of vertical force is involved, vulnerable to side blows. So the non-contact ones, again, we're not worried about. It's a twisting motion that occurs. And really it's a problem. It's not something that happens acutely per se. That ligament has been strained and stressed for a lot of times. And then what happens is eventually just gives way. And that's true with a lot of injuries. We call it repetitive microtrauma, a stress fracture, repetitively hurting the same area, and finally it's letting go. This is the one where we see this triad of injuries: collateral ligaments, cruciate ligaments, and cartilages. Lateral below, typically with the knee extended and very often fixed. Okay, so the ACL are common in runners or any athlete. Okay, with twisting occurs. That was the one with that Rod Woodson, the famous athlete from multiple cities. And so they're showing you the hockey example. Not that I know that the hockey puck would necessarily do it. So again, here you can see this is a famous triad: medial or tibial collateral ligament. You also often see the abbreviation MCL. Meniscus torn rather than just a mini tear, and the cruciate ligament ruptured. And for this kind, these days, there's so much advances in technology that you can do. They've had cadaveric grafts. You typically take grafts. My son had with his ACL, and that was from doing a flip on a BMX bike, dirt jumping. They basically went in and took a little piece of patella and a little piece of the tibia and some of that patellar ligament tendon, and they took that and then inserted it through arthroscopically and basically did a bone graft, because bone heals. You don't want to graft the tendon, so basically you're doing a bone graft following the same line using a guide wire of the ACL. I don't know if that's what it is. He had that procedure 24 years ago. That was just on the phone, but it's still a pain in the ass. Lovingly, parents say that. So that's really the sum and saga about this. I'm going to show you the cartilage tear like I had now. Compression, shear, and stress. And this is the worrisome part. And this is exactly what the orthopedic surgeon told me. I mean, after I felt it, I hurt, I iced it. I took some pain meds, say ibuprofen. It's like, I'm like, I better go see. I made an appointment with our local orthopedic surgeon. I said, it really doesn't hurt now. And he's feeling like, oh, I hurt. And he goes, listen, Lou, sooner or later, some of that cartilage is going to calcify and get locked in one of your joints, and you're going to be doing something. The next thing you know, your leg is just going to go lock up. So I said, and the appropriate course of action, he goes, we operate. It's very easy for this tear. Okay. They don't remove it per se in a sense of going in there and cutting it out. What they do through arthroscopy, you're looking at the joint, fluid is running in, you have fluid siphoning out through two separate ports. You have a side port that comes in, and you introduce a tiny burr, a tiny grinder like you have on a Dremel drill. Basically, you grind down, sterile obviously, grind down the cartilage, suck it out, and it repairs your scar cartilage. That's a classic way of doing cartilage that's there. So this is exactly what it would look like. They would be watching it. They'd pass the burr, grind that down, smooth it out so it's sort of even like this. And whatever filling would be with a kind of scar cartilage. And again, for somebody like me who's, riding in a golf cart on the golf course, probably not going to hurt it again. So that gives you an idea what that's about. So before we get to the arthritis nugget, the big thing is to understand terminology. A sprain is damage. A strain or a stressor is force. So you don't, oh, I strained my knee. No, you sprained your knee. But a strain came from whatever activity you were doing or stressor that you were doing. Sprains, we grade them. Okay, typically first, second, or third degree. It's really mild, moderate, severe, if you want to think of it that way. A first degree sprain, okay, is probably microscopic damage that occurs. It's going to hurt 3 days, 5 days, a week, 2 weeks. Basically, you follow the typical guidelines, whether you're being treated professionally or not. Anti-inflammatories, always take them with food or milk, please. Anybody you're recommending to empty stomachs are bad. Ibuprofen, Aleve, any of those. They all cause gastrointestinal damage. And over time, 70% of the people who take them chronically end up with gastrointestinal damage. Read that as bleeding over time. So the best time to start is now. Elevated ice for the first 24 to 48 hours, not heat, because that increases swelling, and swelling is a problem, and elevate them. Compression is the one. If you are in a clinical class and somebody says, this is how you wrap a sprained ankle, and they do that stupid figure of 8 thing, do not say it. And Dr. Stein said you're a blank blank. It would be bad. It's enough that you'll know and I'll know. Okay, you wrap it like a tube, gradually increasing the compression. Other than that, that's the first thing we learned from orthopedic surgeons. The biggest weapon we have is an ace bandage. Don't use it the wrong way because you can cut off somebody's circulation. Just can't. So any of that figure of 8 stuff, if you see it on the sideline in a football game, it doesn't count. Paying those guys millions of dollars, they need them back in the game. They know that they're going to shoot them up with cortisone and local anesthetic, back in there and play. That's what we're paying. Different. If you're a professional athlete, that's the risk you take. That's why a lot of them have big problems moving around 20 years from now. If you didn't know that. So this is, and now grade 2 indicates that there probably is a greater degree of damage, but probably enough that you can either feel or visibly note a great deal of instability. It's going to take longer. And grade 3 means that there certainly has been a tear. You can either observe it, and again, the MRI would be necessary, some other diagnostic test. And then now you're looking at probably surgical intervention. So that's really where they are. And the difference between the subluxation, partial dislocation, luxation is complete. That was why Joe Burrow wasn't playing, because he had a turf toe, that whole big toe just tore apart completely, and all the surrounding structures kind of went off the top of the big toe, off the base, off the head of his first metatarsal. We've seen those. They're terrible. Hopefully they can do a better job today than they did years ago. Which brings us to the last part. Again, it seems like I hoped I would get to it all today. When you talk about arthritis, it means inflammation. Arthritis is a garbage, because you don't know whether it's bursitis or it's inflammation. Tendonitis, tendon doesn't mean inflammation. Okay, and you treat it all the same way. If it's acute, pain, rest, ice, compression, elevation. If it's chronic, then that's when the heat and exercise become very, very good. We'll get to all this in a second. You're going to see this side, right? We're going to look at wear and tear arthritis, called osteoarthritis. We're going to look at true inflammatory arthritis, called rheumatoid arthritis, on both sides of that board, but I'll explain it for anybody who's listening. So when we talk about arthritis, it's a generic term, inflammation of a joint. Is it periostitis? Is it capsulitis? Is it bursitis? What is it? So different types of inflammatory or degenerative disease, and that's the word that confuses everybody who learn about this stuff. Inflammatory. They all are sore and inflamed. We all take anti-inflammatories. Everybody prescribes anti-inflammatories. You can get them over the counter. True inflammatory arthritis is the direct result of your immune system It is an autoimmune phenomenon. So when we talk about rheumatoid arthritis, which is the poster child for this, that is an autoimmune disease. And that means your immune system is doing the damage and it presents differently. The most common kind of arthritis is called osteoarthritis. That is wear and tear over time. Is it after sport and injuries associated with sport? Sure. Is it injuries that you might have at home because you really messed up an ankle and twisted it bad, or my knee? Sure. It's something that happens over time and affects most individuals. Don't worry about it. If you're going to get it, you're going to get it. And most of us are going to get it by the time we're my age or older. Sorry. My back is bugging me today. I was doing too much lifting yesterday. So, most widespread crippling disease, I'll buy it. That's a diagnosis if you're going to go clinically. Everybody has it. If you're going to treat anybody, certainly not just middle-aged, but seniors, everybody's got it. Pain, stiffness, swelling, all about it. But they're not all created equal. We probably won't get to the ones about bacteria today, and we won't get to the ones gout, which is metabolic. It has to do with your body's inability to get rid of a sufficient amount of a waste product that we always make, called uric acid. So I'll reserve that and talk about those separately, because I probably don't want to rush going through all of those. And the interesting one, bacteria that they have now, which is really an immunological disorder, and very, very important to learn about if you're going to be around here, or if you live around here, is the most common vector-borne disease. Vector means it's brought to you by a bug bite, an insect, that type of thing. And that is Lyme disease. Ladies and gentlemen, we live here in Lyme disease central. This is part of the life cycle of that particular tick is the deer. Come to my house and look in my yard, and yes, whenever I walk the dog in the morning, you're a deer. This dog thinks they're big dogs. You want to go, a big dog. I don't see those horns very much. Osteoarthritis, wear and tear. We don't know. Wear and tear. Excessive release of enzymes, I'll buy it. Some people hereditarily are more prone to it. Occupations, cartilage broken down faster, possibly. Little, like I was telling you about bone spurs, they get in there, they get trapped in the joint. By age 85, and I'm not that old yet, half of Americans develop it, more women than men. That's a recurrent theme, everybody. Highlight film. Most likely, unilateral means one side. It may eventually occur on both. It starts on one side. It doesn't occur on both sides simultaneously. Bilateral symmetrical. Large joints, knees, shoulders, hips, elbows, ankles. It starts with joint begins to narrow. It begins to flatten or square off. The density of the bone gets thicker and harder. Maybe down the road, as it gets older, it becomes osteoporotic. But initially, it's thick, hard bone. If we were to operate on these, we'd have to chop out every bone. We're talking hammer and chisel. So much fun. And over time, joint narrow. That's really the highlight. And I put narrow here. Joint widthwise widens side to side. That's what I should do. So it looks like this. So it may start a typical joint like this. Down the road, you're going to see the width of it expand. How do you treat it? Basically, both of them are treated the same way. All the conservative stuff, and steroidal and non-steroidal anti-inflammatory drugs, exercise, heat, physical therapy, modified activities, blah, 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 blah. All of those type of things, and if necessary, people will use joint replacement. and they're not always successful, but they've been around for a while. Hips have been around for longer than knees, but they're both around, and there are other joints. This is the problem. This is osteoarthritis, normal aging. You can hear the sound or feel it, called crepitus. So we hear that sound, that term used for other conditions. Again, you don't want to use, this is not narcotic pain relievers or anything like that. Capsaicin, if you did not know, and it's available now over the counter, it was prescription when I first started to prescribe it, a long time ago, 40 years ago. It's from extract of like red hot peppers. And the seeds and the membranes are where they are. And we were using it for diabetic neuropathy pain. At first, now it's used a lot. It's topical. It depletes something that we're going to go over, not to know now. We go over in neurology called substance P. So it's one of these substances that we call a neurotransmitter, and it affects the neurotransmitter rather has a role in pain, conducting pain impulses. So if you take it away, it's not like making the condition better, but it's making the pain hopefully go away. It works in about a third of the patients. This is pretty consistent. It didn't work at all in a third of the patients, and a third of people can't tolerate it because their skin would be, it's all topical, be so irritated they couldn't stand it. Feel like their skin was on fire. My wife would be in that last third. When she tried it for a condition she had, it's like, I'll never use that again. I understand it. That was the same result I had in my patients. This nonsense, here's what I said to the other class. With this, glucosamine, chondroitin, and nutritional supplements not effective. Bullshit. Very effective. Not everybody. They help me. That's the only frame I can give you. I mean, I just bought dog food, 40-pound bag of dog food I was lifting. And what was in it? Glucosamine and chondroitin sulfate. I mean, it's not exclusive to dogs. These are building blocks for cartilage. Some people it helps, some it doesn't. The idea, it's not going to magically make more cartilage. It helped me. I could hardly grip a golf club. I had a tough time shaking hands. This is 20 years ago. Supplements helped me. So, I mean, it's silly to think that we have an age where there's a lot of good nutritional supplements, and you study and read about them, and there's a lot of people online, okay, that have really good ideas. So I'm not going to promote one over the other. I have no financial interest in that. If I think about it, I'll try to ask. This guy's pretty good from California, but I'll try. My wife knows the name pretty well. So, typically, at times I get a bowl of supplements at bedtime. Moving on. This is autoimmune, rheumatoid arthritis, systemic lupus erythematosus, psoriatic arthritis. They're all variations that behave differently, but effectively your body attacking itself by way of your immune system. That is a true inflammatory arthritis. They both are inflamed. And the treatments are both similar. It's the presentation. The immune system attacks its own cells, even though it usually arises between ages 40 and 50. Worrisome times, second through fifth decades is when it starts to rear its ugly head. 15 through 55. And everybody here, ladies, it is much more common by far and away. In my practice, 80%. Statistically, 3 out of 4. I found it to be a little bit higher. Maybe associated because I have a lot of diabetic patients. We think diabetes has an autoimmune component. Okay? So maybe that skewed it, but it's still, you've got to think about this. When I tell you about Lyme disease next time, I mean, I understand that was part of the differential diagnosis because Lyme disease is immunological, even though it's bacteria that cause it. Signs and symptoms include joint pain and swelling. And so anemia, systemic, low blood count, the bone is not dense, it becomes osteoporotic, and other things. This is what you look for from a clinical perspective. First, small joints. Wrist, hand, ankles, maybe a little. Small joints and bilateral and symmetrical. It typically starts on both sides nearly at the same time. Okay? Swelling and widening, it doesn't start by narrowing because it's inflammatory, causes the joint to swell from what's going on. Joint widens. The swelling, all the fluid tends to leach out the calcium source, so the bone density decreases. The joints narrow, they can't move as much. Wide, they become unstable. They tend to dislocate or partially. And eventually the arthritic changes become part of it. It's a totally different picture that you see there. I'm almost done with that. I'm going to go over that. So it begins with inflammation of the lining. Osteoarthritis is more of the bone first. Blood cells migrate, they release chemicals, and they form, well, you can read through this. This is what they form. It's a thing called pannus. It's almost, I hate to say waste product. It's an accumulation of white blood cells and chemicals that adhere to the cartilage and begin to deteriorate it. That's there. And what happens, so effectively you're deteriorating the cartilage by a different method than wear and tear and narrowing. And ankylosis could occur in both of them. That's where the joint can't move. Fancy name. Okay. Different things. There's a lot of different agents. I had a variation of this that I probably got from immunotherapy, which was designed to help treat my bladder cancer. So I got this sort of an oddball reaction to it. They have me on, and you've heard it on TV, Humira, which is a tumor necrosis factor agent that blocks it. I've stopped taking it. I didn't feel it helped me enough to put up with some of the side effects. So I have a fair amount of experience with this. Also, at one point, I took Cosentyx, which works in a different way of treating this. There's a whole lot to it. Those are called biologicals. That I talk about that when I do AP2, when I talk about immune system, but I'm not doing it this year. And like I told the other class, when you have AP2, I'm still going to be here. You still have my email. And ask me questions. I'm happy to help you. It's my job. This is what it looks like. We see either ulnar or ulnar drift. This, when we have fibular drift, they kind of look, they dislocate, we get the big lumps. Nasty. I said there, and we'll say that. And lastly, this chart, I'm talking about the left, which I should. Happy day. So, I asked you about it in the activities for daily living. This is where it's. This is the bell curve. This is, I say good to bad. This is how immunological and autoimmune disorders manifest. It's 50-50. 50% of these you can function pretty well. So typical bell curve, that standard deviation from the mean. 10% of the people carry a diagnosis like rheumatism. You wouldn't know they have it. It doesn't affect them. They carry it. The diagnosis was made because they met the diagnostic criteria. It really impacts them almost negligibly. 40% of those people require medications like the ones you were seeing. It's going to have some impact on. They're going to have good days and bad days, but they can work gainfully. They can work on the floor, nurses, doctors, whatever. There's some days, good days, and bad days. So it has an impact. That's the side you want to be. This is when it gets bad. Half of these people are on the bad side. That 40% it impacts their activities of daily living. And it's all about marriage and grief. Bathe, shower, get dressed, go to the bathroom, whatever, brush their teeth. All about severity. If you're close to the midline, you probably get along. Maybe somebody has to come in periodically to help you with things around the house. On the other hand, you may not, and most likely you're not going to be able to work at home. You can, greater the degree, and 10% you are. We had a case, we didn't have a case, we saw a case where we were students in a rehab hospital where the doctor showed us, and he went in to examine her. We stood at the entryway to the room. Only because she appeared female did I know it was a girl. This gal was maybe, he told us later, she was in her mid-20s. 6 months prior to that, she was perfectly normal. It hit her so hard and intensely that she was about 80 pounds, and he said probably would not survive another 6 months. When he went to examine her, he's touching her, she's just mewling sounds, like a wounded animal. I hate to phrase it that way, person. Because I was seeing this. He walked out of the room. He said, "We're going to go into a separate room and talk about this case because you don't anybody to hear it." This is one of the worst cases I've ever seen. That was rheumatoid arthritis. So I mean, it's that whole spectrum. That's the nature, and and unfortunately, autoimmune phenomena are more common than you would think. So I'll leave it there. I'll finish up with the gout and the Lyme disease nugget, and we start that muscle physiology in earnest Monday. Thank you. Bye bye.